Good morning, everyone. Thank you so much, Sunny, for introducing me, and thank you for inviting me for this conference. Right, today my talk is about interstitial lung disease, and the title is The Roadmap of Children's Interstitial Lung Disease. I will start with this slide. I have no conflict of interest to disclose. And my talk will include the definition of the interstitial lung disease, the pathophysiology, classification, diagnosis, and treatment, and at the end conclusion. So what's interstitial lung disease? It's a big umbrella of a large and heterogeneous group of rare disorder characterized by diffuse pulmonary infiltrates, restrictive lung physiology, means restrictive lung function, and impaired gas exchange, which are associated with substantial morbidity and mortality. And so far, there's at least 200 types of interstitial lung disease. It's still a rare disease with prevalence of up to 16 in 100,000 patients. Okay, I updated this slide from 0.5 to 16 in 100,000 children. And it's still underestimated because of misdiagnosis, lack of an ICD code, and absence of common registers in most parts of the world. Mostly diagnosed at young age, median age of 1.5 years, and it's familial in 5 to 20% of patients. So what does happen? How does it happen? The pathophysiology, it includes abnormal lung development at early age, antenatally mostly, and systemic, it can be part of systemic disease with lung involvement. And it includes lung injury and repair mechanism in conjunction with genetic susceptibility. Actually, the genetic factor is the most important factor in developing interstitial lung disease. And if we look at this diagram here, what happens that we have a recurrent injury and loss of epithelial cell. And normally, I'm not sure if I can point with this one. And normally with normal repair, you have normal tissue regenerations, but the other one on the left side, when you have abnormal repair, apparent repair, sorry, yes. Yeah, but I need this, I need the to arrow. Presentation. Where's the point? Sorry. Okay. Right, so this one here is the normal tissue regeneration, and this one on the other side is the apparent repair. And you can see the thick septation, thick interstitial tissue with abnormal epithelial hyperplasia. So how do these patients present? It's mostly a non-specific presentation, and it's more severe and persistent than expected for at least 4 weeks duration. The most common symptoms they present with is tachypnea, crackles, and retraction, but it can present at any shape. It can come with cough, respiratory failure, pictus excavatum, and clubbing at older age. There's so many classifications over the last 20 years, and most of these classifications are not really quite satisfactory, and there are lots of overlap. But the last classification by Nathan in 2018 is the most practical one that we can use, and she divided the interstitial lung disease to 4 main classes. One is related to infancy, developed in the first 2 years of life. Another one is related to lung primary parenchymal dysfunction, or part of systemic disease, or related to exposure to environment insult or viruses. But still you can see some overlaps between these classes. For example, MIHI that develops in infancy can be a result of surfactant disorder. And diffuse alveolar hemorrhage as well can be a result of vasculitis. So I'm just going through a few examples of interstitial lung disease. Right. Okay. To start with, before the examples of interstitial lung disease, I'm going to go through the approach diagnosis. For diagnosis, like any other disease, we start with the clinical pictures, symptoms and signs. If you have a symptoms and signs suggestive of interstitial lung disease, then we start with the least invasive investigations, like lung function, spirometry, and DLCO. Obviously, this we can only do in older children, at least age of 5, not in infancy, which mostly of the interstitial lung disease would start at earlier age. And then we try to exclude other more common causes of these chronic respiratory symptoms like cystic fibrosis, immunodeficiency, congenital heart disease. Then we go for chest CT scan, and this is the most crucial investigations in interstitial lung disease. This will tell us if there is interstitial lung disease or no interstitial lung disease. And then we carry on with more investigations. If I go back to the chest CT scan, as I said, chest CT scan can say there is no interstitial changes, and then we start looking at other cause of our problem, or there is interstitial lung disease. And even CT scan in some cases, like MI-high, it can give us the actual diagnosis. If CT scan tells us there is interstitial lung disease, but we don't know which one, then we have to continue with more investigations, including blood tests, and then more invasive investigations like bronchoscopy and eventually biopsy if needed. So CT scan doesn't just help us with diagnosis, but also it tells us about the distribution of interstitial lung disease. And as well, it guides on where we're going to biopsy if we decide to biopsy, where is the site of the biopsy. There's an agreement to use thin section, the smallest field of view, and a sharp resolution algorithm for the chest CT for the interstitial lung disease. And for infants, there is a new protocol with reduced radiation. But what we're going to see on in the CT, we're going to see most of the cases, diffuse ground glass opacity, but also we can see mosaic changes, septal thickening, cyst, nodules, bronchiectasis. And then we know now there's an interstitial lung disease. We need to know which interstitial lung disease. So we carry on with a blood test, and most important is the genetic test. And every year, more children are associated with genetic defect. And this raises the old conceptions about lung biopsy was the gold standard for diagnosing interstitial lung disease. For genetic tests, we have the whole genome or exome sequencing. And some countries in Europe and North America, they have their own gene panel of interstitial lung disease. But to be honest, I think the whole genome exome sequencing is more accurate, more reliable. There's a problem, obviously, with this genetic test. The speed takes at least 4 to 6 weeks, and it's quite costly. And these are just examples of so many genes that related to interstitial lung disease. Then we carry on, and if we need, we can do flexible bronchoscopy and get a bronchoalveolar lavage. And the bronchoalveolar lavage helps us on identifying if there is hemosiderin-laden diffuse alveolar hemorrhage, or if there is lipid-laden macrophages indicating aspiration, or if there is lymphocytosis or eosinophilia-related interstitial lung disease. For the lung biopsy, it can be done through a VAT or with open lung biopsy. But there is some problems with the lung biopsy that even a given histological pattern may be a manifestation of many different gene disorder, or the same gene disorder, the same child disease can give us different histological pattern. And also for the same person, for the same child, the histological pattern may change over time. Obviously, there's limitation. Not in every center you can do biopsy, and you need really an expert center to read the biopsy. And obviously, it has its own risk. Now I'm going to go through a few examples of interstitial lung disease. To start with, the one which starts at early age, even in neonatal period. And two of them, one is the congenital alveolar dysplasia. This one is a lung development arrest during canalicular phase in the second trimester. And this is a lethal disease. Within a few hours, the patients with severe respiratory distress, severe respiratory failure, and die. And the chest X-ray is completely white. The CT is a ground glass ossification with septal thickening. Another one, which is also lethal, is the alveolar growth abnormalities, and also starts in infancy, early infancy, mostly related to other diseases in infancy, like trisomy 21, neuromuscular disease. And if you look at the histology that we have there, the first one on your left is the normal term, normal alveolarization, and the rest, you can look at the alveoli, they're quite abnormal, large, and not tidy, in pulmonary stenosis, trisomy 21, and X-prem, or premature baby with PEG. And this is CT scan for a trisomy 21 with interstitial lung disease, the alveolar growth abnormality. Look at the cystic changes, especially subpleural cystic changes. But it's not always this gloomy when you have interstitial lung disease infancy. In fact, there are few interstitial lung disease in infancy with a good prognosis. One of them is the PIC, which is pulmonary interstitial glycogenosis. And this is a disease where the glycogen is accumulating in the alveoli. And if you look at this CT scan, the first one, the CT scan is these two for the same child. The first one is at age of 3 months with complete ground glass appearance, septal thickening and cyst, and then at age of 14 years with improvement. Another good one with good prognosis that starts in infancy is the knee high, which is neuroendocrine cell hyperplasia. There are lots of endocrine cells still in the lung, and it has the characteristic positive pompicin staining. But for this knee high, we don't really need even to do any genetic test or any lung biopsy to identify it's knee high, because the CT scan is quite characteristic. You have ground glass appearance in the anterior segment of the lingula and the right middle lobe. And obviously, the famous surfactant disorders, we're all aware about it, because this was like the first interstitial lung disease to be identified, especially surfactant protein B. This was identified 30 years ago. And there's surfactant protein B, there's C, APCA, and TTF1. And there's surfactant protein A, but this is just for adult. I mean, only one reported case in children. The surfactant protein B is the most fatal one. And the rest of them, they have variable prognosis, and also they can present either infancy or later on. I have to mention that APCA3 is quite common. In fact, APCA3 is the most common genetic cause of respiratory failure in a full-term baby. So if you have a full-term baby at your neonatal unit with no obvious cause, always think about APCA3 if you have like the ground glass appearance in the chest X-ray or the CT scan. Other more rare cases like filamin A mutation, and filamin is a protein that cross-link actin, and it's a X-linked dominant. That's why boys, they die at early stage. Most of the children with filamin A mutation that we see are female, but they come with their problems like severe diffuse lung disease, like the CT scans that you see here, and it shows hyperinflation of the upper lobe, atelectasis of the lower lobe. But also they have periventricular nodular heterotopia, tracheobronchomalacia, and severe pulmonary hypertension. And obviously we diagnosis by a genetic test. And a recent discovered child is the Copa syndrome. And this is a multisystem disease as well, the Copa syndrome, and it's a genetic autoimmune disorder with autosomal dominant, but lots of sporadic mutation. And with this Copa mutation, we get the interstitial lung disease, and sometimes with alveolar hemorrhage. You can see in the histopathology here, the blood cells are seen there in the alveoli. And the CT scan shows cyst and interstitial lung disease. Of course, it also affects the kidney and the joints. So if you have a child, an infant with a kidney, joints, and interstitial changes in the chest CT, think of COPA. Can I go back? Oh, sorry, I went back. Right, and next is the interstitial lung disease related to exposure or environmental insults. The most common is the hypersensitivity pneumonitis, and it can be due to bird allergen. So be aware when you take a full history from the patients and family if they have birds at home, or fungus allergen, or the humidifier disinfectant. And this was reported in the Korean outbreak in 2006 when so many families had this, I've got the picture of that humidifier that they used, and the children ended up with severe interstitial lung disease. Vaping. Right. Vaping is like the newcomers and a cause of interstitial lung disease, especially in teenagers. I had a case myself a year and a half ago here in Dubai with a 14-year-old with a severe interstitial lung disease due to vaping. I was admitted to the PICO, ventilated for 2 weeks, continuously for 2 weeks. So vaping, it causes lots of problems, and we know that vaping was reported in so many cases in USA just before the pandemic started in young adults who've been vaping even for a short time with interstitial lung changes. And it can cause giant cell interstitial pneumonia, hypersensitivity pneumonitis, lots of things, name it. And these are examples of chest CT scan of teenagers with vaping. What about treatment? So treatment did not really change much the first line treatment did not change much over the last, let's say, 10 years. And it mainly includes steroids, systemic steroid, hydroxychloroquine, and azithromycin as a first line treatment. And if these treatments do not work, then we think about immunosuppressing drug, whole lung lavage if there is PAP, or lung transplant or stem cell transplantations in some cases. Depends on the cause, obviously. But there are so many new specific treatments, most of them are still under trial. So it's quite promising. So hopefully we'll get appropriate treatments for all these rare diseases. The prognosis varies. It's overall around 15%, and highest in developmental disorders, like the first two I mentioned earlier in my talk, and lowest in NIHI, in PEG, and even in surfactant protein C mutation. Pulmonary hypertension is the single greatest clinical predictors of mortality. So children with pulmonary hypertension, they do worse than other children with no pulmonary hypertension. Right. Important considerations when you have a child with interstitial lung disease. These children need to be referred to a tertiary center. They can't just be managed in a small hospital by a general pediatrician. Wait to go back. You just go back to the previous slide, please. So these children really needs to be in a tertiary center with experience with interstitial lung disease. There's always other issues beside the lung problem, the feeding problem, the nutrition that we need to address, and parent experiences and perspectives, like trained parents, how to deal with this disease if the children was on ventilator, has tracheostomy, on oxygen, etc. And obviously psychological support. So what's the take-home message from this talk today? The child represents highly heterogeneous, rare respiratory disorder with large spectrum of age of onset and disease expression. The clinical awareness of potential child helps to speed up diagnosis and reduce parental frustration. There are several classification systems, but of a greater importance is the application of standard investigation pathway for potential child. The use of genetic plays an increasing part in diagnosis, and lung biopsy is not the gold standard, but rather a stage in the journey. Morbidity and mortality associated with these disorders remain substantial, and multidisciplinary team approach is essential both for diagnosis and management. Thank you. And I just have to mention that in 28th of February is actually the Global Day of Rare Disease. Thank you. Any questions?